Thank you, Prof. Jumjum. I think we'll keep the questions to the end of the session. Next, we would like to call for Prof. Bernstein again for the last presentation in this lecture, which is lessons from talking with a patient.
Because it's about a form of fairly simple research that I've become engaged in the last decade since I did a master's in bioethics. And this it's not expensive research, and you don't have to have a molecular biology lab. Anybody can start one of these studies tomorrow. So what neurosurgeons can learn from talking with patients, a qualitative journey. And what this is really about is the investigation of the patient care experience using qualitative research. So, what is qualitative research? I had never heard of it until 10 years ago when I did my master's in bioethics. Qualitative research is the study of complex phenomena in natural, not experimental settings, giving due emphasis to experiences and views of the participants involved. It's been long used in social sciences research. It's not used much in medical research, and allows investigation of questions not addressable by quantitative methods. And a perfect example, I was having a conversation a few minutes ago with Dr. Faisal Al-Otaibi about why patients in Saudi occasionally refuse brain surgery. So how would you find out? By doing a qualitative study. Get the next 30 patients who refuse an operation and do a qualitative study, you've got your answer. So here's a beautiful thing. It helps with patient care, and it helps with research, and it helps with academic productivity. So data collection in qualitative research is usually with interviews with key informants or surveys or focus groups or participant observations. And the gold standard, just as the randomized controlled study is the gold standard for outcome studies, the gold standard here is semi-structured interviews. I won't go through how the data are analyzed. But you develop themes from the interviews. A theme is a central idea that appears frequently in the interviews. It's allowed to emerge from the data. It's not preconceived. And they're usually more than one, usually in my studies 3 to 7. So you do a structured face-to-face interviews with patients or other subjects to the point of saturation. And then you do interviews. The interviews are audio taped, transcribed, and subjected to thematic analysis. What is saturation? Saturation is the point at which no new information will arise from further interviews. And in general, that's usually about 30 interviews. So you start with the interview guide and you give it to your research ethics board and you have a protocol and you start your study. And what I'm going to do quickly in the next 10 minutes is run through some of the simple-minded studies that I've done over the years, which have been, I think, a contribution to the literature, and they've also made me a better doctor by doing them. So the first group of studies is on patient satisfaction, which includes issues like pain, anxiety, timeliness, and courteousness of care, meeting of patient expectations, etc. So what is patient satisfaction with outpatient lumbar discectomy? So in 1996 in Toronto, I started to do all discectomies as outpatient. And it's not done everywhere that way in the world, but about 10 years after we started, and I'd done hundreds as outpatient where they go home the same day, I said, we better find out from the patients whether they're okay with it. So we did a qualitative study. And what I'm going to show in each of the slides here is some of what we learned and below where it's been published. So the satisfaction with outpatient discectomy was high. There was a lot of pain on the drive home, which I didn't know because I'd never asked. So we learned to be better doctors in a simple way in this study by giving a lot of painkillers before they got in their car to drive home in the afternoon. So very simple-minded study, but we learned something. Similarly, what's the patient satisfaction during the gamma knife radiosurgery experience? We have 2 gamma knives in Toronto. Satisfaction was high. Patient's information level is high. And again, there was a lot of pain on putting on the frame and on taking the frame off, which we just didn't really take that seriously until we spoke to the patients and they told us. So you learn, there's sometimes things are so obvious you don't see them until you ask. So here's my baby, awake craniotomy. Are patients satisfied with awake and outpatient craniotomy for brain tumor? In other words, would you rather have been asleep for the operation? Some of what we learned. Satisfaction was high. Patients were initially surprised it could be done, and trust in the surgeon is paramount. And I green highlight trust because when you talk to patients, the theme of trust comes back and back and back. So I'm not sure what you do with your low-grade gliomas here, but we often follow them in Toronto unless they need an operation. So what do patients with low-grade gliomas experience anxiety while we're using the wait-and-see approach? So they're getting their MRI every 6 months. Is that anxiety-provoking? No. Patients do not experience excess anxiety while waiting. They would prefer to avoid the risks of surgery until it is deemed absolutely necessary. So that's the general rule we use in Toronto. If it's a benign-looking low-grade glioma with no mass effect, and if the patient is happy with not surgery, then we follow them. So here's patient safety and error. This is the other research that I didn't show you in the previous talk. We also did a qualitative study on error. Error is a medical and ethical issue, and it's an inescapable reality. And we did 2 studies. What do patients understand about errors happening during their brain tumor operation? And we did a study in 2004, and we did a study last year. Worry level varies from patient to patient. Trust is very important. In other words, trust that the surgeon will do his or her best, even though if they make a mistake, they'll do their best. And worry about their disease is, of course, more important than worry about error. Talking about error is a good thing. So we asked patients at the end of the interview, did you find this disturbing that we actually talked to you about the possibility of errors? And people said no. Talking about error is a good thing. So a subject that many of you may think is taboo to patients, maybe it isn't so taboo. Surgical education. This is one of the things that's close to my heart. So I've done a couple of studies on surgical education. Surgical education relates to the ethical tension of how to teach the surgeons of tomorrow without compromising the care of the patient today. Is letting the resident do most of the operation on this patient, compromising this patient, so that this resident will know how to operate on this type of patient in 10 years when he or she is on their own. So the first study, what do patients know about the role of residents in their surgery, and does it worry them? Patients don't know what residents do, but they trust the system. They would like to meet a resident pre-op if he or she is operating on them, and this is relevant in the Canadian system where patients come to the hospital the morning of surgery. They're not admitted the day before. Notice trust comes up again and again and again when you talk to patients. Surgical education 2. What do we surgeons tell our patients about the role of residents? Are we being transparent with our patients about the role of the residents in their care? No, we don't. The surgeons trust in the concept of graded responsibility because that's how they were taught. And they also appreciate the trust that their patients put in them. They don't take it for granted. So again, trust keeps coming up again and again. And the third bit in the trilogy on education is, do residents experience moral angst related to their role as on-the-job trainees? So all of the residents, just think of the last situation you had where you felt morally uncomfortable. And what we learned from talking to the residents in this case was, yes, they do get moral angst when either they feel they're working beyond their comfort level, like they're doing a case that's too difficult for them, or when they disagree with the staff's decision about the case. Those are the 2 scenarios. And we asked them at the same time how they prefer to learn. And the model they prefer is a junior resident operating with a senior resident with the staff supervising but unscrubbed. So in our system, that's what they related to us. And there I am supervising a resident and a fellow, or 2 residents. So neuroethics, and this relates, Faisal, to your stuff with the brain-machine interface, because we're getting to that. Neuroethics is the intersection of neurosciences and ethics. And examples include ethical issues related to functional MRI, deep brain stimulation, BM, brain-machine interface. These are, how far do we go? How far can we ethically go with a machine that replaces part of the human brain function? A lot of people would find that an uncomfortable situation from an ethics perspective. So how do we find out if it's ethically okay or not? Well, we talk to people. So the first study was on patients. During neurosurgery, patients think that functional neurosurgery for enhancement, i.e. for non-disease states, is okay. Functional neurosurgery is morally acceptable for diseases like depression, according to patients. Functional neurosurgery is morally dubious for enhancement of normal states. Then we put the same question to surgeons. And we talked to surgeons in Toronto, we did a North American survey, and we did a world survey through the WFFNS. And what did surgeons think? Well, surgeons had the same view as patients. Functional neurosurgery for real psychiatric diseases like depression is morally desirable. Functional neurosurgery for enhancement is morally dubious. So maybe there's not an ethical marketplace for things like, the stuff that Faisal talked about. So the last study I'm going to tell you about is one that we just finished on deception. So deception is the failure to have 100% truth-telling either on the omission or commission side. It's done to protect the patient or the doctor, and it's probably commonplace. Probably every surgeon here has told a little white lie or withheld a little bit of information from the patient to spare them grief. So I wanted to do this study on deception. So I went to the literature, and the only thing that I found was a study of doctors. And it was from 20 years ago. And the study stated, to come to the bottom line, when forced to make difficult ethical choices, most physicians indicated some willingness to engage in forms of deception. They appear to justify their decisions in terms of the consequences and to place a higher value on their patients' welfare and keeping patients' confidences than truth-telling for its own sake. So in other words, they said, yes, we would tell a little white lie to spare the patient extra grief. So this was my hypothesis going into this study. Surgical patients will accept small bits of deception designed to spare them grief when full and accurate disclosure of all of the information the surgeon knows or thinks would not alter the course of action. So we took 33 post-op brain tumor patients and asked, is this scenario that I'm going to tell you deceptive? And if it is deceptive, is it ethically acceptable? We used convenience sampling over a 3-month period a year and a half ago, and we had an interview guide with 10 scenarios, and I'll show you one of the scenarios, and I know that every surgeon in this room has been in this situation. The post-op MRI shows a shadow that may be post-surgery effect, but you strongly suspect it's a bit of tumor that was missed. You tell the patient, when the patient asks, you say, the MRI looks a little fuzzy. Let's see how the next one looks in 6 months. And the reason you're doing that, minimal deception, is because you want to put off the discussion until you're sure that it is recurrent tumor. You don't want to cause that patient grief in the 6 months worrying about it. So we've all been in this situation, and we've all done this. And there were 9 other scenarios similar to this. Here's another one. A patient has a complication due to what you consider an avoidable technical error. When the family asks what happened, you say, the surgery was much more difficult than usual. We did the very best we could. In other words, it's a bit of a platitude. It's not a lie. It's just a little bit of mini deception. So the results of this study, patients want to know everything the doctor knows. At least these 33 patients did. And even mild deception would not be acceptable to them. So again, I learned something about patients that I didn't really suspect. I thought that people, after 26 years as a brain tumor surgeon, I was fooled by talking to the patients and learning from them really what the score is. So the advantages of qualitative research are the ability to study issues not explorable with quantitative methods. It's a form of audit and quality assurance as well as research. It's inexpensive, it's fun, it's easy. There is an endless supply of questions and of study subjects. Disadvantages are that it's subjective, it's not always generalizable, the data are not as hard as quantitative studies, and it's a bit touchy-feely for clinicians. It's a little soft for us surgeons. It's also not very familiar to surgeons. It's really not used a lot in the world of surgery. So what we can learn is that patients in our system are too shy or respectful and will usually not offer their views about something. But if we ask them, they will tell us. And lessons they teach us can help us be better care providers and also give interesting insights that we just wouldn't know otherwise. And in the last 10 years of doing these qualitative studies, I've learned a lot about patients that I thought I knew and that I didn't know. Not everything that can be counted counts, and not everything that counts can be counted. So that summarizes qualitative research versus quantitative research. And a lot of these studies I've had help from PhDs, but a lot of these people were medical students when they did the study, or they were undergraduate students. There are many neurosurgical residents in there that helped with the studies. So it's not like molecular biology where only a few people can do it. Everybody can do it. I also like to acknowledge Canada Institute of Health Research grant and my chair. And of course, thanks to the patients. And in our system, patients never say no to participating in a study. If it's a randomized controlled study of gene therapy, injected into the brain, that's different. But studies like this, where it's just talking to the patient, they never say no, but we shouldn't take that for granted. With that, I thank you very much. And by the way, while I was early, so I have one more 30-second bit of time. I have to leave early tomorrow morning, unfortunately, and I just want to thank Ahmed and Abdul Rahman and everybody, again, from the bottom of my heart for a fantastic invitation. It's a real honor and pleasure to be here, and also to be reunited with some of my Saudi sons. And I really have had a wonderful time, and you've put on a great meeting, and thanks a lot.
Thank you very much, Professor Bernstein. We'll entertain some questions now about the first paper. If I may start, Professor, about the disclosure of errors. If an error, Professor Bernstein, sorry. If an error had occurred that had not and was corrected and had not manifested itself with a clinical problem for the patient, do you think is there a need to report this to the patient? That's first part. Second part, if the resident, the one who did the error, would that be reportable? And the third part is how many disclosures have led to litigation?
Okay, so I'll probably forget them because I tend to forget things these days. But I'll go backwards. I'll go backwards. So there was a study done in the United States that compared a group. They took a series of errors. It was done in Kentucky, and patients who were notified earlier had a less chance of suing, and the size of the suit was smaller. Okay, so that answers the last question. The first question was about disclosing an error that doesn't really affect the patient. I'll give you a perfect example, and this has happened to me twice in my career, and it's the classic dropped bone flap. So that you're putting the bone flap back on, and in both cases, for me, it was the resident that did it, but it was my case, and I take responsibility. So the flap hits the ground. You're putting the flap back on after a meningioma. In our hospital, it's illegal to flash a bone flap and put it back. So you have to throw the bone flap away and reconstruct with mesh and methacrylate. So there's a perfect example, because the patient would never know, right? And it had no impact on them. So do you tell that patient? So my answer would be yes, because I think any reasonable person would want to know that part of their body was lost and was replaced, even though it has no impact on them. So the answer is yes. I think if a reasonable person would want to know, I think we should disclose. Was the second one about residents? So Yeah, you know what? In my database, one thing I've not recorded is who does it and who doesn't, because I didn't want to get into that. But my observation, having recorded errors now for over 2,000 elective cases, is that the error is done by the staff as often as the resident. That's not a numerical fact, but it's my observation.
One small question. If the error was, just to clarify, sometimes the error happens when you're not there. Like I left the case and the residents are closing and an error would happen. So what would I do there? Does the fault, do I say that this is my case, this is my error, or do I say that the resident did it? So what do you do? What will you do?
That's a good question. It's your responsibility as the staff. But if the patient asks you who did it, you would have to be honest. And I had one case earlier in my career where a very tired resident at 2 o'clock in the morning put a burr hole for a subdural on the wrong side. There were no consequences, that he did it on the correct side. He hadn't called me, which was another error. He didn't call me. So the family asked me, were you there when it happened? I said, no, I wasn't when the resident did it. So there was no legal action or anything. But I would never volunteer, I would never blame a resident, but at the same time I would never lie to a patient. So if they asked you
that. Thank you so much for this study. Actually, I enjoyed the study of Dr. Lozano, and also I enjoyed your talk. And it's very interesting. I think the time factor is the most important, because when you publish, for example, one paper, case report about tuberculosis from Saudi Arabia in 1980, it has more citation than if you publish 20 or 30 papers in 2011. So the time of publication is very important regarding the citation. And I think when you do a study like this, we have also to consider the number of publications and the quality of research, as you considered also certain things like the experimental, it should be considered. So I think the time factor is the most important thing in the citation numbers.
As well as the quality of the journal. The paper we may be referring to was in neurosurgery, which is a very strong journal about biopsying a brain lesion, such as TB. And hence being in neurosurgery and having some eminent authors also helped to make it a leading paper. Any more questions from the secretary?
Any more questions for the papers? Okay. Last presentation.
Thank you, Dr. Bernstein. My question on your last presentation is, when you conduct these interviews, do you conduct them to your patients only or to your colleagues' patients? And if you conduct them to your colleagues' patients, how do your colleagues feel about asking the patients? Because some patients, if you go and say, I want to make an interview, why, what happened, So can you clarify that point for me? Thank you.
First of all, of course, the interviews are not personally done by me because I'm too close to the patient. It's usually done by students or research assistants. Many of the studies that I've done, I've asked my colleagues to be involved. One, because I want more patients. Two, I want more than just one surgeon's patients. Three, I'm trying to support my colleagues. And then I speak to their patients on their behalf, and I always invite them to be co-authors of the paper. Yeah. The more the merrier.
Okay. Thank you very much, everybody. Before we start the next session, the neurosurgery residents of Saudi Arabia, the residents who are in the program and the residents who finished the program would like to acknowledge Professor Zain Al-Abidin Jamjoom for his role in setting the standards for an excellent neurosurgery training program, and I want to express their appreciation to him for inspiring them and for being a godfather, a brother, a mentor, a preceptor. Prof. Jamjoom has just finished the 2 terms as chairman of the scientific committee for neurosurgery training at the Saudi Council for Health Specialties. I call Prof. Jamjoom. And Dr. Faisal will say, Dr. Jamjoom will say.
بسم الله الرحمن الرحيم. يطيب لنا نحن الأطباء في البرنامج السعودي لجراحة المخ والأعصاب أن نتقدم بجزيل الشكر والعرفان لسعادة الدكتور زين العابدين بكر جمجوم لجهوده العظيمة وإخلاصه المتفاني لبناء وتطوير البرنامج السعودي لجراحة المخ والأعصاب، حيث ارتقى في فترة قصيرة لمستويات مقاربة للبرامج العلمية المرجعية في هذا المجال. لن تستطيع الكلمات أن تخبر بما في قلوبنا من محبة وتقدير وعرفان لمقام هذا الرجل العظيم. نأمل من الله تعالى العلي القدير أن يجازيه عنا خير الجزاء، هو القادر على ذلك سبحانه. I would like to take this opportunity to thank a great teacher and a mentor, a man of honor whose continuous effort and wisdom have helped to establish and build a modern neurosurgical training program competing with regional and international programs. Dear sir, words cannot express how we feel towards you, and we have nothing to say in return except that God bless you. God bless you for what you've done and continue to do in this field. We would like that you accept this small token of appreciation as a symbol of our feelings. Thank you.
I'm truly touched by this gesture, which I did not expect, because I was really doing my duties, which I felt part of it is to convey some of the experience and knowledge in neurosurgery which I acquired abroad. Of course, it was a challenge because when we started, we were very few people in neurosurgery, and luckily, slowly, our number increased. The main difficulty in the program in the initial years was to get the infrastructure running smoothly. We had initially a program which was relatively loosely structured, so the examination were arranged as needed, individually, sometimes without previous preparation. Sometimes somebody just drops in a board meeting and we have to do an examination for him. So I think these things, luckily, we could overcome, and we could now have a very well structured program. And I'm sure there are still a lot of things to be done. Definitely there are a lot of challenges, and definitely there are a lot of things that can be improved. One of the things which can be improved is definitely to try to get a link to an international program to get a comparison of the level of our people with the people abroad. This is done in some of the specialties, like in the radiology. They are performing the US exam, the annual US exam on the residents here, and getting a comparison of the level of the residents in Saudi Arabia. I think such a thing can be done here. There are other things which I'm sure should be improved, mainly the manual skills. I think we still do not have a very well standardized measure of how much practical skills a resident acquires during the training. And I think these things need definitely to be improved. And I'm sure these are the challenges for the next staff who took over the program. I thank all the residents I dealt with, and I do apologize for them if at some stage I had to take hard action sometimes, and also if the examinations were sometimes a bit difficult, but I can say most of it came from my brother. Thank you very much.
Good afternoon. We'll continue the sessions, and this session will be for our residents who are going to present their work, and most of the work being done by them, prepared. So we will. It will be great for all of us to stay and listen to them and have your feedback to them. The time is short for each resident. Some of them they have very good research that would like to hear, but they were giving 5 minutes each. So because of the time factor here, I think I'll be on the clock for every 5 minutes. So I hope all the residents finish his work in a due time. We'll start first by Dr. Hamoud Dash, who's a graduate of our Saudi program. Hamoud is a resident. He did his training, most of it in Riyadh, in King Faisal Special Hospital, and he's going to talk about the National Neurosurgery Resident Survey, the trainees experience. Go ahead.
Thank you, Mr. Chairman, Organizing Committee, for giving us the chance to present our work. The neurosurgery training program is relatively new in Saudi Arabia, and luckily, this year we are celebrating the 25th anniversary of the first training program being established in the Kingdom, King Faisal Fellowship. Since that time, there is a significant increase in the number of the trainees and the training centers in the last few years. The aim of our study is to assess the trainees' experience and challenges during their training. And our methodology was designed to capture the factors that influence the resident training, and the overall methodology was to see how the resident perceive their training, what they think about their training, their challenges, the challenges they are facing, difficulties, and we did that through a questionnaire that covers 21 items that include working hours, operative exposure, educational activities and research activities, satisfaction, and others. We used the electronic mailing method to transmit all the surveys to all neurosurgery residents involved in the current training program, and the data analysis also received by the emails, and the analysis was done by an independent investigator who was not involved, Dr. Faisal Tabi, who was not involved in the data transmission nor collection of the data. The response rate of the survey was 60%. 16 residents from Riyadh were responded, 2 residents from the Eastern Province, and 4 only from the Western Province. We're going to discuss some of the results because of the short time that we're going to discuss some of the results only due to the short time. Most of the trainees, 70%, cover 6 to 8 on-calls days per month, and 60% of the residents worked up to 80 hours per week, and 40% worked for more than 80 hours. And interestingly, 55% of the trainees felt that their exposure to various neurosurgical technique or exposure procedures were inadequate compared to the latest survey in the state, which is 39. 36% of the residents consider moving abroad to another neurosurgery training program, and 72% did not receive any research technique at any time during their training. The current training program does not satisfy 45% of the trainees. Interestingly, when we asked those trainees, do you have an example of successful neurosurgeons who have been graduated from the current training program, the majority respond to yes. Most of the trainees in Riyadh City agreed on one training center that relatively provide a better training and more surgical activities, King Fahd Medical City National Neuroscience Institute. In general, the level of the training was scored good level by most of the responders. There is a considerable concern over the trainees' exposure to various neurosurgical procedure, and limited involvement in the research activity was noticed. Final remarks, our data, or the result basically based on a subjective data. The aim of this survey is to have a quick screening and just to perceive what the resident think about their training program. Each result needs to be further studied in an objective way, and we are going to run a phase 2 part of the study that will discuss the resident surgical activity operative based on additional quantitative data. We would like to thank all the residents who have been participated in this survey. Thank you very much.
Thank you, Mahmoud. I think we will leave all the questions and comments to the end. We'll carry on with the second speaker, who's Ayman Jamjoom. He's a resident in his first year at the Western General Hospital in Denver, and his paper will be about the predictive value of MR diffusion metric on prognostic outcomes in preoperative glioblastoma technology.
Assalamu alaikum. My name is Dr. Ayman Jamjoom. I'm currently a first-year resident at the Western General Hospital in Edinburgh, Scotland. And today I'd like to just give you a quick run through a project we undertook looking at the prognostic value of diffusion MRI in preoperative glioblastoma multiforme. So what I'd like to do really in this kind of 5-minute whistle-stop tour is give you an overview of the background of the project, talk you through my aims, methods, and results, and finally talk you through my conclusions and discussions. So glioblastoma multiforme is the most common primary malignant brain tumor, and despite very aggressive therapy, including surgery, chemo, and radiotherapy, prognosis still remains very poor. Diffusion MRI is a modality of MRI that looks at the amount of diffusion of water within a tissue, and it's been shown to have an inverse relationship with gliocellular density. So on one side here, you can see a sparsely cellular tumor would have quite a high diffusion measurement, or the one below, which is a lot more densely packed, would have a low diffusion measurement. And studies have shown that tumors with low diffusion values have a worse prognosis. So the aim of our study was to retrospectively assess whether diffusion MR metrics predicted overall survival and time to progression in histologically confirmed glioblastoma multiforme. And we did this by identifying preoperative patients from a neuro-oncology database between January 2007 and February 2011. And once we'd identified the patients, we got their diffusion maps, and using the software known as GIM software, we identified 2 metrics. The first one, and the most important one, is known as the minimum mean diffusivity, or minimum MD for short. And this was calculated by correlating on the diffusion map region of interest that equated the T1 contrasting tyrosine tumor. I put anywhere between 3 to 5 of these regions of interest, and the one with the lowest minimum MD value was taken as that value for that particular patient. The second metric we looked at was known as the normalized minimum MD, and that was essentially calculated by dividing the minimum MD for that patient by the diffusion value of the supraventricular white matter on the contralateral side of the tumor. We will look at 2 primary endpoints, so that was overall survival and time to progression. We also collected a range of different patient parameters, including age, grade, gender, their performance data based upon the Kanofsky score, the treatment modality, whether they'd had radiochemotherapy, and whether they'd had surgery or not, i.e. a biopsy, no surgery, or resection. When it came to our statistical analysis, we divided our metrics into 2 classes based upon the median. We then undertook a univariate and multivariate analysis using the Cox proportional hazard model. And with the multivariate analysis, we took forward the 2 most significant patient parameters, and we set our p-value at 0.05. So what we found was that we identified 46 patients in total, and they had age range between 24 to 83. And the MR diffusion metric characteristics, the median characteristics, were the minimum MD was 6.1 times 10 to the minus 4, and the normalized minimum MD was 0.9. When it came to the outcome data, we found that the average overall survival was 280 days, so less than a year, and that at the closure of analysis, there were 31 events. Time to progression was, on average, was 175 days, and 37 patients had progressed by the time we'd close analysis. Now, this is the univariate analysis. So what we found was actually that patients with lower diffusion metrics, so with lower values, had a worse prognosis compared to those that had higher values based upon the median. And this is generally in keeping with the fact that they had a higher risk of shorter survival and time to progression. However, none of these actually went on to reach statistical significance. When we moved on to multivariate analysis, and in this case we took forward patient gender and treatment modality, what we found was that patients with the minimum MD below the median had a statistically significant poorer prognosis in terms of overall survival and time to progression, and a statistically significant poorer time to progression with regard to lower values of normalized minimum MD. So what do these results mean? I think the most important thing that they show is that patients with a minimum MD value below 6.1, below the median, when adjusted for gender and treatment protocol, had almost 3 times higher risk of having a shorter survival and had over 5 times risk of having a shorter time to progression. And these results suggest that patients with glioblastoma with focally reduced mean diffusivity confer poorer prognosis pre-treatment, pre-surgery, radio and chemotherapy. And this may be explained by the fact that we identify patients with a greater cellularity or smaller cell GBMs, which tend to have a poorer prognosis. There were limitations. It was a retrospective study, small sample with non-uniform treatment modality. And essentially what we're saying is that this may be a useful tool to identify patients with poor prognosis pending prospective validation studies. Thank you very much.
The next speaker is Dr. Ali Jazeer. He's a senior resident at Riyadh Military Hospital, the president of Saudi Young Neurosurgery Group. He's going to talk about, are there enough neurosurgeons in Saudi Arabia?
Bismillah ar-Rahman ar-Rahim. Good afternoon. I would like to thank the organizing committee for their support. Bismillah ar-Rahman ar-Rahim. Good afternoon. I would like to thank the organizing committee for their support and accepting our participation. I'm presenting, are there enough neurosurgeons in Saudi Arabia?
Assalamu alaikum, Dr. Sagaf. Just I heard about the complaint of the resident about the limited number of researches they are given to them. In the last 5 years, since we started the program in the Western region, we met 2 types of residents. There are residents who are seeking the researches, and we try to give them. And there are residents who are really difficult even to convince them that about the importance of being involved in researches or in paperwork and these things. How to differentiate between the two in this study? Because
in our study, we asked a specific question. We did not get into details whether you did or you did not did. We asked them whether you received any educational activities about how you are going to perform a research, how you are going to conduct a study, how you think, how you analyze. This is what we asked. We did not ask the resident whether you did or you didn't. So the research activity itself doesn't mean that whether you did or you did not. It's about, did you receive any education about how you are going to do a research, how you conduct a research, and this is what we meant. We said it's around. We said that the numbers no. What we meant is, sorry, can you repeat your question? Sorry, you said
the question. Because some of the residents, even to convince them and to be involved in the research, and some of them are not. Can you trace or make a discrimination?
No. This is what we said.
Research.
This is what we said.
Is the cause because they don't want to be involved, or because they are getting less number or less chances to be involved in research work?
That's what we said. We're going to run a phase 2 study analyzing each item separately in a specific questionnaire. So that will conduct exactly what is the limitation that they are facing in the research activities. Are they're not interested, or are they don't get easy access to the data? This is what we are going to run in phase 2 study.
It's not yet.
It's not yet.
Okay. Thank you.
So we're going to proceed with the next presentation.
Are there enough neurosurgeons in Saudi Arabia? What would happen if you needed emergency neurosurgery but your local hospital did not have the resources? Trained staff or a critical care bed immediately available to treat you. You would be taken to the next closest hospital with available neurosurgical resources. But what if the hospital was located hours away in another city? Your condition could deteriorate and you might not survive unless access to appropriate timely care was assured. Saudi Arabia is considered the biggest country in the Middle East, second in Arab world, fourth in Asia, 12th in the world, with 2,240,000 square kilometer. 27,136,90,77 people are living in Saudi Arabia. How many neurosurgeons in Saudi Arabia? What is the acceptable rate of population neurosurgeon ratio, PNR? Where do we stand in comparison to the developed and developing countries? So the aim of our study to establish a census of the existing certified neurosurgeons in Saudi Arabia and to calculate the estimated BNR according to the current Saudi population and compared with the existing countries. Methods. Data were collected from different sources: Saudi Council of Health Subspecialties, Saudi Association of Neurological Surgeons, Central Department of Statistics and Information, and personal contact information, and looked at the BNR per each of Saudi major and intermediate cities. Result. We have a total of 176 certified neurosurgeons. We divided the data into two groups, two categories. Major cities where there are more than 5 neurosurgeons. We had a total of 8 cities. Intermediate cities where there is less than 5 neurosurgeons with a total of 14 cities. These are the major cities, 8 major cities. Riyadh is the biggest number, 53. Then Jeddah, Ad-Dammam, Al-Khubur. And the intermediate cities, it's around 14 with less than 5 neurosurgeons. The nationalities of the neurosurgeons, the Saudis were 57, then the Egyptians 42, Syrians 13, Pakistani 11. So the BNR in Saudi Arabia is 154,187, Riyadh 98,000, Jeddah 110,000, Mecca is the biggest number, 306, Medina 157, and Dammam is the best BNR, 64,000. It is almost similar to the state BNR. Al-Hufuf 110,000. The target to achieve the desirable ratio, which is the WHO suggested ratio 100,000, is 271 neurosurgeons. So totally we are achieving only 60% of the supposed desirable number available for the data of 2010. Expected population in 2020 is 33 million and a rate of growth 2.62. We need 33 neurosurgeons to achieve the perfect ratio if it is still there. This is the 2004 WHO graph, where we see the Saudi Arabia is less than or more than 100,000. Harvey Cushion apparently suggested that the proportion of 1 neurosurgeon to 1 million population was adequate. By 1971, 20,000 neurosurgeons were in the US, reaching a PNR of 100,000. In 1993, there were 4,156 trained neurosurgeons for an estimation population of 252 million, given a PNR of 61,000. Winfield Penfield and Kenneth Mackenzie pioneered Canadian neurosurgery. In 1971, there were about 100 neurosurgeons serving population of 20 million Canadians. In 1993, the number has increased to 193 for a population that has increased to 27 million, given a PNR of 142,000. Tanzania is the worst PNR with 18 million population. Malawi, there is no neurosurgeon. So I'll go to the conclusion. The question of how many neurosurgeons are needed cannot be answered solely. It is indeed very difficult to answer if theoretically we assume that the range between the average and the median comes relatively close to the actual needs. Then some countries can be identified above or below these figures. There is no information about the type of activities of the individual neurosurgeon if working in a hospital, in a private practice, or a non-clinical occupation, nor the work profile, whether working in a generalist or subspecialist. So the conclusion, workforce and neurosurgical manpower should consider the vast territories of Saudi Arabia and the demographic distribution in the future plans of neurosurgeon employment, accompanied by providing acceptable facilities to maintain international standard of service. Thank you.
Thank you, Ali. So I guess the conclusion, we don't need any more neurosurgery real. The third paper actually by Dr. Rakan Bukhari. He's a first-year resident at the University of King Abdulaziz in Jeddah. He's talked about the conceptualization of professionalism by resident at King Abdulaziz University Hospital in Jeddah.
I'm Dr. Rakan Bukhari from King Abdulaziz University, Jeddah. I would like to thank the organizing committee for giving me the privilege of presenting among my sorry for that. I'm Rakan Bukhari, a neurosurgical demonstrator and attached resident at King Abdulaziz University Hospital from Jeddah. I would like to start off by thanking the organizing committee for affording me the privilege of presenting among my mentors and peers. Today's presentation is going to be about professionalism and residency training. This is an abstract term from the world of medical education. Perhaps this would explain the rather lengthy introduction. Now, in 2002, the ACGME and the RRC for surgery in the United States mandated the inclusion of certain competencies in training programs as a quality measure. It listed 6 competencies to be specifically taught. Relevant to our discussion today is the fact that professionalism has been stressed in an equal manner to medical knowledge and patient care. CanMeds, which is the Canadian counterpart to that, reiterated that stressing. So in essence, professionalism has been given weight comparable to medical knowledge and clinical skill. The reason why they have been so late to identify this is that it is a difficult quality to define. Even the ACGME, when attempting to define professionalism, merely listed attributes of what it believes professionalism entails. So why is it important? Well, there is an emerging body of evidence indicating that unprofessional behavior exhibited by an individual during medical school residency is a very strong predictor of disciplinary action taken against the individual once he starts his clinical practice. There is also evidence that unprofessional behavior is very disruptive to the work environment, affecting productivity, teamwork, satisfaction, increasing rates of burnout and depression among both learners and practitioners. It also has a detrimental effect on patient care. A patient who encounters a physician who exhibits unprofessional behavior is less likely to follow the treatment plan. It also resulted in increased complaints and litigation against that individual physician. It's also a gift that keeps on giving. Unprofessional behavior, if not addressed, may be regarded by learners as acceptable, and they may actually incorporate these behaviors themselves. So the question is, can we teach it? Well, not in the traditional sense. The reason being is that if you change the goal from medical education, for professional education, from producing a moral physician, which is an unattainable goal, to that of merely providing them with the toolkit or skill sets they need to address ethical dilemmas or to fulfill the values and ideals in their clinical practice, in that case, yes. And in fact, it is being taught. A number of articles are now emerging in the medical education and surgical literature describing the experience of leading institutions worldwide. A paradigm shift in the education of professionalism is that it shifted from the traditional Halstead model of an apprenticeship to a formal and deliberate teaching. Informal teaching results in invariable results and is therefore no longer accepted. This is proving effective. This is an article just recently published. This is an article very recently published in the American Journal of Surgery describing NYU's experience 5 years after incorporating it into their curriculum. It had two surprising results, mainly that residents exposed to professionalism in their curriculum tend to act more professionally as they progress through the years. It also shows that although initially viewed as an oddity, by the end of the 5 years, residents valued these courses and considered it to be an integral part of their education. Now, we at my school of King Abdulaziz want to implement this program. So in essence, to do that, we need to assess the current values and opinions of our residents on professionalism as a baseline and identify the current sources they describe as most influential. This is the first study also in our country and in our region that we know of. This is the study. It's a cross-sectional questionnaire-based study with a 77% response rate among the 230 residents at our institution. We believe that's a representative sample. It's a modified version of a validated questionnaire. It has several domains, most of which are really unsuitable for this lecture. However, overall, professional qualities are highly rated. However, one notable note here is that altruism received the lowest score among the ACGME qualities. We'll come back to that later. Also, after presenting them with a list of unprofessional behaviors, the lowest ranked 3 behaviors were refusal of peer review, evaluation, and constructive criticism, not reporting medical errors committed by colleagues, and providing only the minimum accepted care to patients with no ready access to healthcare services. Where I come from, eligible patients, mainly illegal immigrants, the poor, and those who live in rural areas, present a challenge in daily practice. Our questionnaire also showed that the apprenticeship model, although shown to be both inappropriate and productive of very variable results, is the prevailing method of acquiring these values in our school. That is, of course, mainly because of a lack of structured training, a deficiency we're aiming to correct. It also shows that working with consultants and seniors in the hospital was the main source of their opinions and behaviors. Hospital staff coming in second. There was also a notable deficiency in the preclinical years, with our residents mainly saying that clinical years are the only time where meaningful instruction was provided. This has been addressed in the medical education literature recently as a lost opportunity. These are 3 years that can be utilized. It also showed that around half of our male and female residents supplemented their opinions by attending courses and seminars elsewhere. If time permits, we have, from our questionnaire, we identified dilemmas. I'll just go through them. Negotiating the conflict of work and family. Sorry for that. There's also the question of altruism no longer being favorable among residents. This is reflected internationally. The conflict between regulations and the patient's best interests, and whistleblowing or reporting medical errors by colleagues. In conclusion, the lack of comprehensive, deliberate, and structured teaching on professionalism is an important shortcoming of our current education system at King Abdulaziz University. We are addressing that. Emphasis should be made to stress on this quality from the preclinical years all the way to postgraduate training and residency. Dilemmas specific to our culture should be sought and addressed in these courses. Take-home message is that professionalism teaching should follow in the steps of medical and surgical training and abandon the apprenticeship model. professional education is not to be regarded as a luxury, but as a necessity in our current time. Thank you for your time.
Thank you, Dr. Rakan, for your presentation. The next presenter is Dr. Abdelhadi Al-Gahtani. He is a neurosurgical resident R2 in King Khalid National Guard Hospital. He is presenting a review of the 50 top-cited randomized controlled trials published in neurosurgical journals.
Assalamu alaikum. Thank you, Chairman. My presentation is about the review of the 50 top-cited randomized controlled trial in neurosurgical journals. Before I get started, I would like to thank my colleagues, Bakr Jamjoom, Abdul Qadir Baghdadi, and to my professor, Abdul Hakim Jamjoom. Article citation number is the basis for calculating a journal impaction factor and the Hirsch index of a researcher, since there is no other reliable method to measure the clinical strength of the articles, and reviews of top-cited articles in a specialty or related to a disease is also a topic of current interest. It is generally accepted a well-designed randomized controlled trial provides level 1 evidence that carries significant clinical strength and heavily influence our neurosurgical practice. In 2010, Journal of Neurosurgery published a review about the 106 most cited neurosurgical articles. 29 out of 106 were randomized controlled trial. Only 25 out of 29 were published in general medical journals, and on the other hand, only 4 RCTs were published in neurosurgical journals. Top-cited randomized controlled trials in general medical journals have already been identified and examined in the literature. And our objective to identify and characterize the 50 most cited randomized controlled trials published in neurosurgical journals and to increase neurosurgeons' awarenesses of the popular RCTs. For the simplicity, I'm going to refer to randomized controlled trial as RCTs. And by using the article citation numbers provided by Google Scholar in December 2011, we identified and reviewed the 50 most cited RCTs published in neurosurgical journals, and we used the following keywords, and these are the journals which taking neurosurgery as a main specialty field for their publications, and we did analyze for these data. And we found the citation number range from 1,119 to 135 regarding the year of publication from 1978 to 2007. Number of authors per RCT ranged from 2 to more than 10, and almost more than 1/3 of the RCTs had more than 10 authors. And the number of patients per RCT ranged from 10 to 1,120. And we found the top 25, the median 233, and the second 25, the median 114. And 44% of the studies were blinded. And the 50 top cited RCTs appeared in 3 of 11 neurosurgery dedicated journals, and they were predominantly from the United States of America. And also 50% of the RCTs had multi-center collaboration that was national in 34% and international in 16%. Also, we observed centers with multiple RCTs among the top 50. For example, Charlottesville, Virginia had 4 trials about the subarachnoid hemorrhage, which top cited among the top 50. And these are other examples for the centers with multiple RCTs. And here we found the greatest number of RCTs among the top 50 were in the field of traumatic brain injury and subarachnoid hemorrhage. Also, topic repetition among the top 50 was observed. For example, these 4 trials talking about the effect of hypothermia in patients with traumatic brain injuries, and these are other examples for topic repetitions. Here I'm going to show you the top 5 most cited RCTs published in neurosurgical journals. Number 5 about the use of moderate therapeutic hypothermia for patients with severe head injury. Number 4, effect of mild hypothermia on uncontrollable intracranial hypertension after severe head injury. Number 3, about the results of second national acute spinal cord injury study. Number 2, about the adverse effect of prolonged hyperventilation in patients with severe head injury. And number 1, which cited 1,119, about the evaluation of BCNU and or radiotherapy and treatment of anaplastic gliomas. I'm going to conclude with the characteristics of the 50 most cited randomized controlled trials published in neurosurgical journals with the median citation number 184, the median duration for publications 15 years, and the median number of authors 8, and the median numbers of patients 127, and 44% of the RCTs were blinded. And the top cited randomized controlled trials in neurosurgical journals were a product of a teamwork that many had multi-center collaboration from national and international levels. They were predominantly from the United States of America, published in Journal of Neurosurgery and related to traumatic brain injury and subarachnoid hemorrhage. It is possible for a center to produce a number of top-cited randomized controlled trials, and it is a well-designed randomized controlled trials can be top-cited even if it addresses an issue that has been addressed in the past. And these are the list of the top 50. And thank you.
The next speaker is Dr. Wissam Al-Isawi. He's a trainee resident at University of Dammam. He's going to talk about posterior communicating artery aneurysm are associated with third nerve pulses.
Good afternoon, everybody. I would like to thank the organizing committee for giving me this opportunity to present here. I'm actually one of the graduates from University of Dammam, and I'm doing my residency now at the Montreal Neurological Hospital in Montreal, McGill. This presentation was done during my radiology rotation in the Montreal Neurological Hospital in collaboration with my colleague, Dr. Roy William Dudley, and in supervision by Dr. Maria Cortez and Donatella Tampieri. It's the characteristics of the posterior communicating artery aneurysms causing third nerve pulses. A small introduction. Approximately 10 to 20% of the diagnosed posterior communicating artery aneurysms are associated with third nerve palsy. In recent years, several reports suggest that the endovascular coiling of the PCOM aneurysms allows for higher rates of recovery, reaches sometimes up to 100%. Methods. We performed a chart and imaging review of PCOM aneurysms in order to delineate the characteristics of these aneurysms that are associated with the third nerve palsy. We reviewed our database for all patients, 47 patients with 48 aneurysms. One patient had bilateral PCOM on presentation. With available charts and imaging who were diagnosed with PCOM aneurysms, including those people with the third nerve palsy, from January 1998 to October 2010. What results did we have? 10 aneurysms were associated with an ipsilateral third nerve palsy, 10 out of 48. 9 out of the 10 aneurysms had been successfully endovascularly coiled, and 6 out of these 9 had complete recovery of the third nerve palsy, which is around 66.7%. Aneurysms associated with third nerve palsy had a significantly greater average height. So these aneurysms in which patients presented with the third nerve palsy showed a statistically significant height, and they showed also greater average aspect ratio than those aneurysms which were not associated with the third nerve palsy. And average aspect ratio is simply dividing the height of the aneurysms over the neck width. We didn't find any statistical difference in the, we didn't find any difference between the two groups in terms of the width, the neck size, the lateral angle of deflection, which is the angle from the horizontal plane on the lateral radial or angiographical view. There was no statistical difference in these. Importantly, and this was found during doing the study, we didn't put in mind to measure this aspect, which is aneurysms causing the third nerve palsy were much more frequently associated with what we call pooling of the contrast within the aneurysm dome, and we will show some pictures about that. These aneurysms was associated with a very high average rate of about 80% of the third nerve palsy patients. That suggests that the pooling of blood within the aneurysm may contribute to deleteriously the third nerve palsy or third nerve impairment. This is a simple demographic data showing the number of patients. We had 10 with third nerve palsy in comparison to the total patients, which is 48. The average sex and average age, which was non-significantly or non-statistically significant. The sex, surprisingly, all the patients presenting with third nerve palsy were females, but this was not statistically significant. And maybe because it was a small number of patients, but we have no statistical significance in that. This is the presentation. 6 of these patients presented with only 6 nerve palsy with no other symptoms. Subarachnoid hemorrhage with third nerve palsy was seen in 4 of these patients with third nerve palsy. Sides, it was equally distributed between the right and the left side. Persistent fetal circulation was observed in one patient. And again, which was significantly or statistically significant is the morphology of aneurysm, which we called elongated aneurysm. It was seen in 9 out of 10 aneurysms, and this was, as we said, statistically significant. These aneurysms were more than 8 millimeters in length. Again, the same thing, just the demographic data. The height was the only statistically significant variable. The lateral angle, nothing. And this is what we call the pooling of the contrast. Simply is after doing the arterial phase and the venous phase, you see some of the contrast stays there in the dome of the aneurysm, which we think is the cause of this TNP because it was found in 8 out of 10 third nerve palsy aneurysms. Just for the sake of time, we'll go fast. The discussion, the first report of linking PCOM aneurysms and third nerve palsy was discussed by Jefferson, who said basically the prognosis for functional recovery was extremely poor, which is not right these days. Longly, it has been assumed that the PCOM aneurysms causing third nerve palsy by simple compression of the nerve likely to relieve the mass effect on the nerve. More recently, and I'm skipping here a few case reports to present just the biggest data of 914 patients to make a comparison for clipping versus coiling for PCOM aneurysms. Okay. Simply, it showed that the recovery in these patients, in the clipping patients, was much more higher and statistically significant than coiling. In conclusion, PCOM aneurysms that are associated with third nerve palsy have a greater height and a greater neck aspect ratio, are much more frequently associated with third nerve palsy, along with the pooling effect, which we saw in the angiogram. Collectively, these findings lead us to propose a novel hypothesis in which that the pulsatile contrast mast, or what's called a water hammer effect, is the cause of these third nerve palsies. And thank you.
Thank you, Dr. Wissam. The next speaker is consultant associate presenting vein of Galen malformation, a management challenge. Please, Dr. Umar.
Bismillahir Rahmanir Rahim. I would like to thank the Saudi Association of Neurological Society Organizing Committee for giving me this opportunity. I will talk about a rare vascular anomaly which occurs in most commonly present in neonates. So this is vein of Galen malformation. So I will talk about the vein of Galen aneurysmal malformation. This is the outline of my talk. The Claudius Galen, he described the deep cerebral venous system in 2nd century. It's the anatomy of the vein of Galen malformation. Vein of Galen, this is formed by the union of 2 internal cerebral veins. It lies in the quadrigeminal cistern, and it drains into the inferior sagittal sinus and leads to the straight sinus. Definition of vein of Galen malformation. Vein of Galen aneurysmal malformation are characterized by arteriovenous fistulas in the choroid fissure, supplied by choroidal arteries and drained to the dilated median vein of prosencephalon, which is the precursor of vein of Galen, and embryonic drainage of the choroid plexus. This anatomy of the vein of Galen consists of a dilated midline venous channel fed by choroidal arteries and thalmoperforator arteries, periclosal arteries, and the other arteries. and venous drainage through the falcine sinus and other persistent cerebral venous sinuses. Embryologically, during the embryonic stage, the choroid plexus is supplied by the anterior choroidal artery and the anterior cerebral artery and choroidal artery and drained by the median prosencephalic vein of Merkozgi. Later, the development of internal cerebral vein results in the regression of the cranial part of the median vein of prosencephalon, and caudal part becomes the vein of Galen. But if failure of regression of the cranial part of the median vein of prosencephalon caused by persistent arterial venous fistula result in dilatation of this vein and leading to the vein of Galen malformation. So this occurs in 6th to 11th week of development, and the insult causing is unknown. The vein of Galen malformation is associated with other vascular anomalies. Venous anomalies are more common as compared to the arterial anomalies, and the most common venous anomaly is the persistent falcine sinus and the occipital and marginal sinus. Straight sinus may be absent, hypoplastic or thrombosed, and the jugular veins or sigmoid sinus may be hypoplastic. This is showing the persistent falcine sinus, and the other picture showing the stenosis of the jugular bulbs. This is the persistent limbic arterial arch, arterial anomaly. Epidemiologically, it accounts for less than 1% of vascular malformation, but the most common pediatric intracranial vascular malformation. It accounts for 30% of the pediatric intracranial vascular malformation. 60% cases present in neonatal period, and males more than the females. Classified by clinical classification, Gold et al. Classified in 1964 into 3 types: neonatal, infantile, and children and adult, and angiographic classification proposed by Ribad, Yazergil, and Las Junior. This is the Ribad classification divided into anterior fistula, prosencephalic fistula fed by the anterior cerebral artery or anterior choroidal, middle cerebral, and posterolateral choroidal artery, and the inferior are mesencephalic fistula supplied by the posteromedial choroidal artery, thalmoperforator arteries, chorioregional artery, and superior cerebellar arteries. And this is the Las Junior classified into 2 main types: vein of Galen aneurysmal malformation and vein of Galen aneurysmal dilatation. And dilatation, these are the secondary types, and the aneurysmal malformation, vein of Galen, they are further divided into choroidal and mural type. This is the choroidal type of vein of Galen malformation. And the choroidal type is the most common, most primitive, most aggressive, and most challenging to treat. It presents neonatal period with high output congestive artery failure. Many fistulas communicate to the anterior aspect of median vein of prosencephalon, and feeding arteries form an arterial network and then open into the median vein of prosencephalon. And the feeders are usually bilateral. And the stage embolization is preferred for choroidal type AVM. First intervention is to decrease the massive flow from the fistula, and the later intervention attempt to ablate the malformation completely. This is the mural type of vein of Galen malformation. It's less common, present in infancy. Fistula could be single or multiple, unilateral, bilateral, and the fistula is located in the infralateral wall of the vein of Galen and supplied by collicular and posterior choroidal arteries. So I will show some of the. This is the vein of Galen malformation classification by the. This is the patient MRI with vein of Galen malformation. This is the angiography showing type 3 vein of Galen malformation, and the this is the coiling and the coiled into the vein of Galen, and this is the high flow fistula. The coils are pushed against the torcula. And what do you think happened after this? Patient has this perfusion pressure, normal perfusion pressure breakthrough and hemorrhage, managed with intubation and ventilation and in ICU and with the external ventricular drain. This is the patient post EVD, and this after 3 years he has encephalomalacia of right hemisphere and compensatory hypertrophy of the left, and this patient after 3 years.
Thank you.
Thank you very much.
Next speaker is Dr. Ahmed Al-Aqil. He's an intern, Division of Neurosurgery, King Saud University. He's going to talk about clinical and radiological predictors of independent walking following surgery for patients with advanced cervical spondylometaphy.
Ladies and gentlemen, good afternoon. We would like to thank the organizing committee for giving us the opportunity to present our paper today. Our topic will be about the clinical and radiological predictors of independent walking after surgery for patients with advanced cervical spondylotic myelopathy. I'm Ahmed Al-Aqil, a medical intern from King Saud University. Cervical spondylotic myelopathy is a common spine disease that can be associated with devastating consequences, one of which is impairment of walking. Factors that may predict the ability of walking following surgery are not well defined. It's commonly assumed that the preoperative functional status is a determinant of post-operative outcome in any surgical procedure. As you can see, the functional level before cervical spondylotic myelopathy surgery could be assessed using the numeric scoring system. Numeric score 4 and the numeric score 5 represent the advanced group of cervical myelopathy. The previous literature mentioned several clinical and radiological predictors of the outcome for patients with cervical myelopathy. Our primary goal was to address a quantitative measurement of signal change on T2 weighted image MRI and their correlation with the functional outcome. We designed a study. It was a retrospective review and included all patients with cervical spondylotic myelopathy who could not walk independently and underwent surgery from 2003 to 2007. We reviewed the patient's demographic and pre-morbid conditions and attempted to contact all patients, 38 patients. MRI studies were reviewed by a single neuroradiologist who was blinded to the clinical status. The sample size was a consecutive 48 patients, 24 of a numeric score 4 and 24 of a numeric score of 5, with a mean follow-up duration of 24.7 months. As you can see, this table represents the characteristic of study population. 83.3% of a numeric score 4 can walk independently after surgery, comparing to only 33.3% of a numeric score of 5. As you can see in the picture, the one with the fuzzy border represents the type 1 weighted image on T2. The sharp border represents the type 2 weighted image on T2, and the last one represents the T1 signal intensity. The preoperative neurological status was a predictor of outcome after surgery for patients with advanced cervical spondylotic myelopathy, as you can see in the figure. T1 weighted image signal intensity and type 2 weighted image signal intensity were a predictor of poor outcome following surgery for patients with advanced cervical spondylotic myelopathy with a statistical significant p-value. As you can see also, the T2 length in the whole sample in the numeric score of 4 and the numeric score 5 was a predictor of poor outcome following surgery for patients with advanced cervical spondylotic myelopathy. We did a logistic regression analysis. It was a forward stepwise analysis. After we do it, we find that T1 weighted image signal intensity and the length of T2 weighted image signal intensity were a predictor of poor outcome following surgery for patients with advanced cervical myelopathy. So our study corresponds with the literature. Patients with a better preoperative neurological status had a significantly better chance of walking after surgery. Neurospinal canal width was a predictor for independent walking. Based on our study, as the length of T2 weighted image signal intensity increased by 1 millimeter, the risk is increased by 1.43 times. The risk for dependent walking in patients with T1 weighted image increased by 8 times compared with patients without T1 weighted image signal intensity. As you can see from this table, our current study corresponds with the literature. The current study is the first to demonstrate that independent walking after surgery was less likely in patients with longer signal change on T2 weighted image MRI study. Other factors including age, sex, duration of difficulty walking, type of surgical procedure, and the presence of comorbidities did not correlate with the surgical outcome following surgery for patients with advanced cervical myelopathy. Our study limitation it was a retrospective design with a variable follow-up duration. MRI was examined by one neuroradiologist, and it was conducted in a single institution. Our conclusions: in patients with advanced cervical spondylotic myelopathy, the better the baseline walking, the less the signal change on MRI, and the wider the spinal canal, the better their ability to walk following surgery. Surgery should be recommended before patients progress into advanced stage, where recovery is less and the need for resources is large. I would like to thank my mentor, Dr. Amr Al-Habib, for his constant help, amazing support, and infinite advice. I would like to thank the organizing committee, Prof. Ahmed Al-Ammar and Dr. Abdurrahman Al-Anizi, for this great event. And thank you.
Thank you, Dr. Ahmed, for your presentation. The next presenter is Dr. Majid Zahrani. He's a senior resident neurosurgery, King Abdulaziz University. He's going to talk about ossification of ligament flavum in the thoracic spine. Please report.
Thank you, Dr. Raisa. Thank you, my colleagues. My case report is about ossification of ligamentum flavum in thoracic spine. The case is a 48 years old Saudi Arabian woman presented with a gait disturbance that gradually worsened over a period of 9 months without urinary or bowel dysfunction. On examination, she was unable to stand without assistance with a spastic paraparesis 2 to 3/5, and there was a loss of vibration and proprioception sense and sensory level below the T7 level. Here, deep tendon reflex and ankle clonus and Babinski sign was positive. CT scan revealed a narrow spinal canal resulting from a dorsolateral V-shaped hyperdensity at the level of T7 to T10. MRI scan in T1 and T2 show this hypointensity, which cause a dorsal compression on the spinal cord at the level of ligamentum flavum. Ossification of ligamentum flavum is a pathological condition that causes symptoms radiculopathy and myelopathy. Olive occur in thoracic and less frequently in cervical spine. A mechanical stress, growth factor, and trauma are most common reasons for the development of ossified ligament. Usually encountered in East Asian population and exceptionally reported in Caucasian people, and usually affect adult 40 to 60 years of age. And the mechanism of hypertrophy of progression of ossification is confined to ligamentum flavum only and does not extend to neighboring spinal bone arch. A bone morphogenetic protein, vascular endothelial growth factors, and transforming growth factors, which is especially the morphogenetic protein 1, which is a key molecule regulating cartilage formation, and a member of transforming growth factor superfamily, have been related to development and growth of ossified ligament. Most cases of OLIF occur in thoracic spine, and then next one thoracolumbar, and rarely in cervical spine. Thoracic OLIF is most frequent, noted in patients with diffuse idiopathic skeletal hyperostosis, fluorosis, diabetes mellitus, and including spondylitis. And it's only in 2% of all spine surgeries. The number of OLIF affected segment varies. 40 to 60 have a single segment interlaminar disease, and up to 25% of OLIF is multi-segment, and 30 to 50% of patients coexisted with OPLL, ossified posterior longitudinal ligament, as seen in the cervical T1 and T2. And here we show the dorsal compression at the thoracic level plus the OPLL, and this is a CT scan. Clinical presentation. Asymptomatic OLIF may be relatively common condition in elderly population, which is more common in male than female, and occur in 38.5 in thoracic area, 26.5 in lumbar, and 0.9 in cervical. Usually involve occipital headache for those patients with cervical OLIF, and neck pain, and later sensory disturbance and in upper and lower extremities, plus gait disturbance. In thoracic, usually they presented with back pain, sensory disturbance of lower extremities, gait disturbance, and paraparesis. Image, MRI, and CT scan. MRI, there is 3 types of OLIF, usually named as isolated, contagious, and non-contagious, and another CT scan is lateral, diffuse, and thickened nodular, which account for 55%. Management, posterior decompression with laminoplasty or in-block laminectomy combined with a lateral fusion is mainstay treatment for cervical OLIF. For thoracic OLIF, multi-level fenestration or in-block laminectomy are usually performed. Ossified ligament should be removed carefully because usually it adherent to the dura. In our case, patient underwent thoracic posterior decompressive laminectomy. Ossified ligament was slightly connected by dura and removed in block. Patient post-operatively start to improve gradually. This is MRI follow-up 5 months post-surgery. We show a good decompression and also signal changes due to chronic compression. Prognosis and outcome overall not to be optimal because of the long-standing compression of ossified ligamentum flavum at spinal cord. Preoperative symptoms duration is important. Surgical outcome depend on the severity of myelopathy. Thus, earliest it's operated, the better outcome. Conclusion, ossified ligamentum flavum have been rarely recognized as a primary cause of thoracic myelopathy, and pathogenesis is still poorly understood. Further researches and study OLIF cases are necessary for early correct diagnosis and therapy in order to avoid poor clinical outcome. Thank you.
Assalamu alaikum. First of all, Bismillah ar-Rahman ar-Rahim. I'm Afnan Osman Khotani, graduated from King Abdulaziz University in Jeddah. I did this study with Prof. Jamjoom during my elective in National Guard Hospital. It is concerning about the efficacy of early pharmacological thromboprophylaxis in traumatic brain injury. It is based on the review of articles written in the literature. First, we know that the venous thromboembolism is highly in traumatic brain injury patients. Its incidence without prophylaxis up to 54%, and with prophylaxis it's much less. It's up to 3.8%. But also the pulmonary embolism in the first day of brain injury, it's about 6%, and in the first 4 days of injury, it reached 37%. So, in this issue, the Brain Trauma Foundation recommended the mechanical prophylaxis using intermittent pneumatic compression in combination with pharmacologic thromboprophylaxis using low molecular weight heparin or unfractionated heparin. However, there is an increase in the risk of expansion in intracranial in intracerebral hemorrhage, and also there is insufficient evidence to support one particular agent with the specific dose or timing of administration. As a result of this, an arbitrary role of starting prophylactic pharmacologic thromboprophylaxis 5 to 7 days post the injury. So the purpose of our study is to examine the efficacy of using the early thromboprophylaxis in reducing thromboembolism and its effect on the brain injury progression based on the published evidence in the literature. What we did is we collected English language articles reported, which was reporting on this subject in the duration of 2000 to 2011. Also, we collected only the patient series, not reviews, and the report includes both the incidence of the venous thromboembolism and the progression of traumatic brain injury. We considered the pharmacologic thromboprophylaxis as early if it was given at the first 72 hours after the brain injury, and as late if it was given after 72 hours following the traumatic brain injury or not given at all. We used this data to collect items from the articles, like number of patients, mean age, gender ratio, Glasgow Coma scale, polytrauma, injury scoring, injury severity score, rate of craniotomy, IVC filter, and some data. Also, we collected those items, and we found that we calculate a combined rate for venous thromboembolism and traumatic brain injury progression in early and late pharmacologic thromboprophylaxis. Also, we calculated the relative risk, and 95% confidence interval were calculated as well for the incidence of venous thromboembolism and progression of brain injury. We found that we used 10 articles in the last decade, and we considered them suitable for inclusion criteria, and they were all retrospective without randomization, and some of them was lacking the control. They were implying the evidence-based medicine level 2, category 3. And the early group, the group that took heparin prophylaxis in the early days, they showed venous thromboembolism rate of 4.5%, whereas the late group who took the heparin prophylaxis after 72 hours or none, okay, was 9.2. which was statistically significant. Whereas for traumatic brain injury progression, it was statistically insignificant because early was much less than late. It is most probably due to confounding variables or even the selection bias. We faced many limitations in this study. So the questions that still need answering is how effective the early heparin prophylaxis in protecting and in progression of brain injury. So as we use the prophylaxis heparin in the first 72 hours following traumatic brain injury, it appears to be associated with reduction in incidence of thromboembolism. Whereas the generalization is not possible due to some limitations and also, as we said, lack of randomization. So we concluded that neurosurgeons should consider early pharmacologic thromboprophylaxis and traumatic brain injury 48 to 72 hours post the injury, and the decision should be individualized and tailored for each patient according to the extent of hemorrhage on the original CT scan of this patient and the stability on the following up CT after 48 to 72 hours, and also the coagulation profile and hemodynamic stability. Also, a randomized control trial is required for this subject. Thank you very much.
Last presentation of the session is traumatic T10 retrothesis in a 5-year-old boy. Case report and review of the literature. Dr. Abdulaziz Abu Babtain is a medical student from King Saud University.
Good evening. I know it's been a long day, so I'll try to make it short. First of all, I'm Abdulaziz Abu Babtain. I'm a 5th-year medical student at King Saud University. This is one of the most beautiful things in King Saud University. We see it every day, but we tend to overlook it, just like a lot of beautiful things in life. So our case is a 5-year-old boy. He's post-motor vehicle collision. He was an unrestrained backseat passenger and was ejected outside the vehicle. He presented to the ER and was conscious, alert, and his pupils were equal and reactive to light. He presented with weakness, grade 3 to 4, and paresthesias of his lower limbs. He also had neuropathic pain. Radiology, you can see here, I think there's a, yes. Anyway, I'll try to use my mouse. Yes, you can see here that there's this vertebra, it's T10. Thank you. Yes, so this is T10. You can see here that it's pushed back, there's retropulsion, and there's compression. So what's weird here is that it's, there's retrolesthesis in relation to T9 and T11, which is very peculiar. You don't see this every day. This is a closer picture. You can also see that there's a fracture up there. This is an MRI. You can see that there's very substantial spinal cord compression, which explains his symptoms. On axial cuts, you can see the fracture again. It's very unusual. You can see that right here. It's a burst fracture. The vertebra itself is very weird looking. This is T11, a level below. You can also see that T11 was involved and that there's a transverse fracture through it. On MRI, you can see again the compression on the spinal cord. So this patient was managed by posterior thoracic laminectomy and instrumented fusion using pedicle screws from T8 to T12. The imaging showed post-operatively that his alignment was good. There was reduced pressure. And at follow-up, 6 and 18 months, he was intact with acceptable alignment. He was running and jumping and was a very happy child. So reviewing the literature about such injuries, we had to look back at the anatomy itself and compare between the adult and pediatric spines to understand exactly what's the cause of such an unusual injury. You can, of course, everybody knows that the pediatric spine has more cartilage and elastic ligaments. It has also less developed spinal muscles and higher discs, the higher intervertebral disc heights. And it's very hypermobile and resilient. So this makes it more immune to injuries and trauma, especially. So reviewing the literature, we found that spinal injuries in children are less than 10% of all injuries of the spine, and in children less than 8 years old, they are also less common. So, as I said, this was a 5-year-old boy. This is very uncommon. These types of spine injuries in children are usually in the cervical spine. This one was in the thoracic spine, another cool finding. So, coming to spondylolisthesis itself, it's a very rare thing traumatic spondylolisthesis, which was only 100 times reported before. And posterior spondylolisthesis due to trauma was reported only 9 times up to 2009. None of the previous reports had a traumatic thoracic retrosthesis in a child. Only one report talked about such a finding in 2 adults, which were also treated by reduction and instrumentation. And it was found that in such injuries, it's very important to treat the patient quickly. So in this case, the injury was at T10, and this is the first ever pediatric case of posterior spondylolisthesis in a higher vertebra than the lumbar spine. There are some other reports of posterior spondylolisthesis due to trauma in children, but they were all in the lumbar spine. And there was also, in the previous reports, subluxation was in relation to 1 adjacent vertebra, as we saw earlier. This is in relation to 2 vertebrae, 1 above and 1 below. So it's very hard to determine the mechanism of injury because this is a child. And at the same time, you don't know what exactly happened. So it is unlikely that the fracture was through the intervertebral discs. As we saw on the imaging, it's intact. There is a chance that this could have been in the vertebral epiphysis on both rostral and caudal ends. Maybe we're not sure about that. We think that hyperflexion centered at T10 caused that the vertebra retropulsed to the back. Another hypothesis is that the fracture is through the neurocentral synchondrosis. Thank you. In children, and there's a report of 3 cases in 2006 saying that the neurocentral synchondrosis can be the cause, although we don't know. Finally, I would like to thank Dr. Amr Al-Habib for for being an amazing mentor. And I would like to thank my dad, who 3 days from now will have passed away 5 years ago. I'm living the dream because of this man. Thank you very much.